to allow I think to join.
You can start anytime.
So good evening or good afternoon, everyone, depending where you are located and from where you are joining us. And thank you for joining our educational activity, which will discuss today Duchenne muscular dystrophy or DMD, which is a very severe, like progressive neuromuscular disorder. And unfortunately, it's a very challenging disorder because of the limited therapies available, and those therapies are most likely like gene targeted and disease modifying therapy that really they are effective, but unfortunately not all our patients have access to them. And we have like very few experts in the region who like are expert in the treatment of Duchenne muscular dystrophy. But today we are really lucky that IVPN NeuroPsychiatry was able to gather like three of those experts from the region to discuss with you the disease, the burden of the disease, the different treatment approach available, but also they will share with you real world clinical cases from their clinical from their clinical like real world clinical practice. I would like just to thank Gen Farm for supporting this educational activity and other educational activities related to rare neurological diseases and rare diseases, so we can elevate the care of rare diseases in our region and ultimately improve the quality of life of patients suffering from rare disease in the region. And I would like to remind you that this webinar is CME accredited because I don't want our moderator, Dr. Al-Muqbil, to be bombarded with questions related to CME. So please, this webinar is CME accredited by 2 credit, and you will receive your certificate of attendance within 1 week of today by email. And with no further ado, I would like to introduce for you our moderator and chairman of the session today. And he will also, Dr. Muhammad Al-Muqbil, will also be delivering a lecture, a real-world clinical case lecture for you. So Dr. Al-Muqbil, he's an associate professor of the pediatric neurology at King Saud bin Abdulaziz University for Health Sciences, and he's a consultant pediatric neurologist at King Abdullah Specialized Children Hospital in Riyadh. He is a dual board certified physician in clinical genetics and genomics and medical biochemical genetic, as well as he a fellow of the Royal College of Physicians of Canada and a fellow of the American Academy of Neurologists. So Dr. Al-Muqbil, he's a very active clinician and scientist, and he has authored numerous peer-reviewed publications, contributed to medical textbook, and delivered invited lecture regionally and internationally. His research focuses on neurogenetic, neurometabolic diseases, and the genetic of epilepsy, with significant contribution to understanding rare neurological condition in the Middle East. Really, your CV is impressive, Dr. Al-Muqbil. It's just a brief summary, and really we are very lucky to have you today as our moderator and speaker. I will give the floor to you to kick off this webinar and introduce the disease and then our first speaker.
Thank you very much, Dr. Maya, and thanks for your kind words. It's my pleasure, actually, to have you all here today with my colleagues, Dr. Ibrahim Tabaraki and Dr. Majid Aziz. So, and thanks, Dr. Maya, for the housekeeping issues about the CME hours. And again, as Dr. Maya already introduced, that during those 2 sessions or those 3 coming sessions, with each one of us, we will have some Q&A time for each one of us. So basically, we will be having the questions by the end of each speaker. And please, if you have any questions, you can just write it in the Q&A box, and I will try to read it after each speaker is done with his presentation. So without any further ado, and to get most of it, I would like to introduce and set the stage for today's presentation. We will be talking about Duchenne muscular dystrophy and a journey through different cases that will be shared by our esteemed speakers. But just as a brief introduction for Duchenne muscular dystrophy, which is probably known for most of the audience here, it is one of the genetic muscular dystrophies known for its progressive disorder with huge unmet needs in terms of different therapeutic interventions. And there is a lot actually of the pipelines that is coming in the near future, hopefully, as we heard from Dr. Maya already, that this disease has a lot of huge unmet needs. It affects about 1 in 3,000 to 5,000 boys each year annually. It's presenting usually by typical earlier developmental delay between the age of 3 to 5 years, usually with delayed motor milestones or abnormal gait with a speech delay. And it is also known for its multisystemic involvement, including cardiac, respiratory, as well as sometimes cognitive issues, as it is also expressed in the brain. As I mentioned, that Duchenne actually is known for its huge multisystemic involvement. As a result, this kind of progression affect not just only the child, but also the families, our healthcare system, and the burden on the community as a whole. Usually boys with Duchenne muscular dystrophy, they will lose their ambulation by early teenage years, usually between the 10 to 12 years of age, around the same time to have the cardiac symptoms followed by respiratory symptoms. And then usually they will lose their life by 20s. Again, we have limited therapeutic interventions despite a lot of products that we have it now in the market that is by different disease or by different mechanisms of action. Still, we are facing huge challenges and obstacles in managing children with Duchenne muscular dystrophies at all levels, and that's what we are gonna share through our clinical cases today from different speakers. And probably by the end of the session, you will find there is a common theme for those different cases that we will be talking about it later on. So with this brief introduction, it's my pleasure now to introduce my dear colleague actually and our senior child neurologist here in Riyadh, Dr. Ibrahim Tabaraki. Dr. Ibrahim, he is a close friend of mine. He is one of our senior child neurologists in the region. Dr. Tabaraki, he is a senior consultant pediatric neurologist from Prince Sultan Military Hospital here in Riyadh. Dr. Ibrahim Tabaraki has a huge experience in treating patients with Duchenne muscular dystrophy. I am actually excited to hear his talk and his experience in managing children with Duchenne muscular dystrophy. So the floor is yours, Dr. Tabaraki. Maybe if you can unmute yourself, Dr. Tabaraki.
Yes, it's coming. Just give me some. Yeah, you hear me?
Yes, Dr. Tabaraki, loud and clear.
Thank you very much, Prof. Muhammad, for your kind introduction, and Assalamu alaikum. So it's my pleasure and honor, and thank you again for this invitation. So today I will speak, as Dr. Muhammad mentioned, about Duchenne muscular dystrophy, and mainly using one real case to illustrate the key clinical lesson, diagnostic challenges, and management insights that this condition demands. and probably there will be an overlap between this presentation and Dr. Majid and Dr. Muhammad lecture. But again, this will be beneficial for the audience. So this is my disclosure. I have speaker agreement with Gene Farm. So, and in this presentation, I will briefly discuss how to identify the key early clinical manifestation of Duchenne muscular dystrophy, and second, to describe and to explain what are our options today for the treatment, and mainly to focus on the exon skipping therapy in DMD. So I will start with this patient which we managed recently in the last year, and this is a 3.5 year old boy and the family came with because there is progressive gait difficulties over the last 6 to 9 months, and as you can appreciate in this pedigree, so there is positive consanguinity, there is 2 unaffected parents, and there is 3 children, one of whom is an affected male and 2 unaffected females. So and as you can conclude from this pedigree, this is very highly suggestive of an X-linked recessive inheritance. So the parents reported frequent falls, difficulty in running, difficulty in climbing stairs, and fatigue after short walks. They also describe intermittent toe walking, and importantly, this boy, he walked late, around the age of 18 months. And there is no regression, there is no speech issue, and there is no cognitive issue. So from examination point of view, he's alert, he's cooperative without any dysmorphic feature. Neuromuscular evaluation shows the classical red flags. The patient presented with proximal weakness, mainly in the pelvic girdle, difficulty raising from the floor with what we call the positive goal sign. There is mild pseudohypertrophy and abnormal gait, and also there is inability to jump and to run. There is no sensory issue. Just to remind the audience, for what does this mean, Goer's signs? So when a patient is asked to raise from the floor, so first roll into their side of all 4, and then they push up with their hands of the floor, and this place their hand on their knee and thigh, and they clip up their own body to reach a standing position. So this, you will appreciate this go sign, and you will see what this mean also calf hypertrophy or pseudo hypertrophy as shown in this video. So from a lab point of view, the CK was markedly elevated around 10,000. To remind you, the normal CK is less than 150. And genetic testing confirmed hemizygous deletion of the exon 48 to 50 in the DMD genes. So why that's important? So the genetic study, is important for the diagnosis. Now we have confirmed Duchenne muscular dystrophy case, but is also important to determine if this patient is eligible for disease-modifying therapy or not. And as you see, 48 to 50 is eligible to one of the exon skipping therapy. So this patient was start on the management, which included both standard of care, And standard of care means we start this patient on corticosteroid therapy. So we have two protocols for corticosteroid. And the one daily steroid, which is 0.75 milligram per kg, and the second, which is the intermittent weekend dosing, which is 5 milligram per kg during weekend, Friday and Saturday. So usually I am using this one. I feel that it's more, the family are more compliant to this, and there is less side effect. Also, the patient is on rehabilitation, and he's supplemented with vitamin D. And also, very important for this family, genetic counseling because the risk of recurrence. How to monitor this patient? So from developmental milestones are extremely important. Multidisciplinary team is also important, as Dr. Mohammed mentioned. More than one system is affected in this disease. So we need to track developmental progress, pulmonary function with regular evaluation, sleep study if needed, or indicated cardiac status with cardiology consultation. Orthopedic are also important to monitor and focus on contracture and scoliosis. Bone density are also very important and to be evaluated with regular evaluation because both of the steroid use and the chronic immobilization risk. So I will focus on two issues in this in the coming slide. So the first point I think is extremely important as you see in this patient. Our patient, he presented early to us, and we have 6 to 9 months delay in the diagnosis, but still we catch this patient early and we start target therapy early. And this is important for you as a pediatrician or family medicine physician to catch those patients early. So because despite the early onset of clinical signs suggestive of DMD, a diagnosis is often not made until 4 years of age or older, and with a diagnostic delay for up to 2 years or more. And from the appearance of the first symptoms. So a disease-modifying therapy for DMD became available, and we can start if we diagnose early, and the prognosis is better if we start early. So shortening the time to the diagnosis in DMD allows timely genetic counseling and assessment of carrier status, initiation of multidisciplinary standard of care, timely initiation of appropriate treatment if available before we have progressive muscle atrophy and probably irreversible muscle disease. And the main cause of diagnostic delay are summarized in the slide. First, delay in to identify early clinical signs, delay to order CK testing, wrong interpretation of elevated ALT and AST, and delay in genetic confirmation. So this is a very nice study. Dr. Mohammed was part of the study about 177 patients with DMD in Saudi Arabia. And you see in the red box, the median age of DMD diagnosis is 7 years. So 7 years, which is late. Yes, the study was done before 2021. So probably we are better now, but still we have a delayed diagnosis. We have still a delayed diagnosis. So I will start with the first, how to recognize DMD early. So what are the red flags and early clinical signs of DMD? So tiptoe walking. So usually as a pediatrician, we are not considering as much as tiptoe walking. We consider usually as a normal variant, but in few patients, it may be the early presentation of DMD. So we have to be careful if the family present to you with tiptoe walking. Other signs may include delayed walking. So many children with DMD begin walking later than usual, often at 16 months or older. Also, they report frequent falls and clumsiness due to the leg and core muscle weakness. There is also difficulty with movement, with the trouble in running, jumping, climbing stairs, or getting up from the floor. We have abnormal gait. Some patients may present with speech delays and language development. So these are red flags and early clinical signs, which as a pediatrician or family medicine, we have to recognize and to test early those patients. So this is the first reason why we have a delayed diagnosis. The second reason is delay in ordering serum CK testing. And in case where the physician initiated diagnostic workup, mainly for global developmental delay, CK should be included, I think, as it's inexpensive, it's available in in all places, and is very useful in directing the diagnosis toward the primary neuromuscular goals. So CK testing is frequently not included in the early diagnostic workup of children with developmental delay, or when motor symptoms are not associated or are associated with neurocognitive deficit, typically not the primary neuromuscular disease. So try to include CK more than you order today. The third reason is the wrong interpretation of elevated AST and AST. So CK testing, as we said, is a sensitive screening tool in the diagnosis pathway of DMD and should always be performed whenever elevated AST and AST are found, especially if you don't have gamma GT or you have a normal gamma GT testing. So elevated CK should always prompt the need for a detailed neurologic assessment and further investigation for query DMD. However, there are still reported cases in which elevated AST and ALT levels were thought to be related to liver, and the patient will be sent to a GI team or hepatologist for more, and still we have patients with Duchenne have muscle biopsy because of wrong interpretation of ALT and AST. And the last reason is mainly delay in genetic confirmation. So in the past, genetic confirmation of DMD, especially for the forms due to small mutation, was not always available. However, I think today, with next generation sequencing is available, more accessible, allowing a diagnosis to be reached without further delay. So we know that around 70% of these patients have a single exon or multi-exon deletion or duplication in the DMD, which is the dystrophin gene, and so we can order MLPA to screen for this. In 70 and in 30% we have a point mutation. And I think it's available. There is several company offering for free this testing, so you can easily ask if you have any suspicion for.
I think we lost to Dr. Tabaraki. Probably it is a connection issue or internet issue.
Treatment option using antisense oligonucleotide. So currently, so as we said, the standard of care, including multidisciplinary team, including steroid and very close follow-up of several systems, mainly pulmonary and cardiac rehabilitation. So the second therapy is the exon skipping and nonsense reach-through therapy. And the third, which is gene therapy, which is evolving rapidly, but still with the regulatory and safety barrier So understanding where each therapy fits based on genotype is crucial. So what about this exon skipping therapy, or what we call the antisense oligonucleotide? So the exon skipping, very brief, what is available today, we have, if you have variant in exon 45, 51, 53, we have two medication for 53. So these are available and approved today. So exon skipping therapy, the first one was approved was for 51 in 2016 by FDA. So the rationale from this that exon skipping therapy use antisense oligonucleotide to restore the reading frame and promote production of a shortened but functional dystrophin protein. And this therapy, in brief, suppresses the function of splicing enhancer sequencing within an exon using antisense oligonucleotide and remove the exon from the RNA. So converting what we call the out-of-frame deletion as occur in DMD to an in-frame deletion, and I will show you a few examples. What does mean frame shift through or out of frame or out of it, and this is no dystrophin protein production, and the phenotype will be the severe one, which is the DMD. In the B, you have what we call the in-frame, a deletion result in incomplete dystrophin protein production, and the phenotype, it will be the milder form of Duchenne, which is what we call the Baker muscular dystrophy, which usually the onset is later. So again, this is to explain out of frame and in frame. So molecular mechanism of exon skipping therapy. This slide summarizes the molecular mechanism of exon skipping therapy. And the top panel shows an out of frame deletion identified in DMD. Inducing the skipping of exon adjacent to the deletion region results in an in-frame deletion, which is in the lower panel, and induced dystrophin protein expression. And this is focused on the exon 51, which is approved, as I said, in 2016. You have at the left no antisense oligonucleotide, and you're right, you have the effect is up to 50 deletion. The number of base deletion is more than 800. It's 871, resulting in an out-of-frame deletion and stop coding appearance in exon 51, and there is no dystrophin protein produced. In this case, inducing a skip in exon 51, as you see in your right, result in an in-frame deletion, which induce the production of dystrophin protein, even it's shorter and less, but it's function. So these are a few studies showing evaluating exon skipping 51 in Duchenne muscular dystrophy with this deletion, and the conclusion of the study, which included more than 50 patients, conclude that using etepsiran and exon skipping, there is positive treatment effect, favorable safety profile, and slowing of disease progression versus natural history. So another important study, and this why? Because this study start more earlier than the previous one, and this medication was used in children from 6 to 48 months, which is following an early diagnosis. And again, even in this group of age, less than 4 years of age, so safety tolerability of exon skipping 51 is demonstrated, and we have better efficacy than if we start in the age group. And the last study I will show you is about the recently published about exon skipping 51 and the cardiac outcome. And as Dr. Muhammad said, so cardiac and pulmonary are the most cause of lethality in patients with Duchenne muscular dystrophy. And as you see, the conclusion of this paper that there is a significant lower risk of reaching left ventricular ejection fracture in patients treated with exon skipping 51, which is important for those patients at risk to develop cardiac problem. What I want to close with three key messages. So the first message is early recognition change the trajectory of children with DMD. So proper recognition of early signs and symptoms, the diagnostic pathway for DMD should now move directly from genetic testing, rather relying, as we are doing 10 years back, on muscle biopsy and pathology. The second important point that management must be structured, anticipated, and multidisciplinary team. And the third, so once you have the diagnosis, you have to correlate with the genotype. And if your patient is eligible for any disease-modifying therapy, because this will change the outcome of the patient. Thank you very much for listening.
Thank you very much, Dr. Ibrahim, for this enlightening presentation. I will just check here if we have any questions. So there is, I'm just looking at the Q&A box. I don't think there is any like pressing questions now. So I just have one question before I will go next, Dr. Ibrahim. So say, for example, for general pediatricians or for primary care providers who is usually seeing children at different age groups for different complaints, how would you, do you have any kind of advice for them when or who should they refer to for some sort of red flags that they should be referred for a child neurologist to complete their workup? And as you mentioned, one of the things that we facing is the delay in the diagnosis. So we try to shorten this gap by better awareness at the frontline providers. So what would be your advice for our colleagues at the front line? How would they or whom they should refer to our clinics or to your clinic, for example?
Yeah. Thank you very much, Prof. Muhammad. I think we tiptoe walking, which is very common in children, but in few cases we have to be careful about that and ordering CK in such patients. This is why my first message. My second message, that there is some cases they may present with developmental delay, including speech delay or even global developmental delay. And in this subgroup, so we have to order also CK. So usually we are focusing on the central causes, but we need also some neuromuscular disease may present with the developmental delay or speech delay. So I think these are my two messages. If you examine a patient as a pediatrician, look for Goer's signs. This is very easy to be done in your clinic. And once you have these red flags plus high CK, whenever you have the genetic testing or you don't have, so you can refer the patient to for more expertise and more investigation.
Thank you very much, Dr. Tabaraki. Thanks again for your kind presentation. So if there is no other or if there is no more questions from the Q&A, so I will be going next. So I will share my screen now. And hopefully it is clear from your end or from your side. So thanks again, Dr. Tabaraki, for setting the stage, actually, because this will make my life much easier. And as he already mentioned, Dr. Tabaraki, that there will be some overlap, or I would say actually even some redundancy between our talks, because basically we will be sharing same messages with similar scenarios with different patients. So this is my disclosure. I received the honorarium fees from GM Farm for the purpose of this talk. However, this has nothing to affect with the content of my talk. So the way how I decided actually to put it is just to share all the cases that has been started on some sort of a disease-modifying therapy. And I decided that to present it from the end. So I would show basically the severe end of the spectrum. So I want to highlight how much those patients are affected and how much actually we don't do, I would say maybe a good job in caring for such children with Duchenne muscular dystrophy, unfortunately. So the first case, this is 11 years old boy, currently 11 years old boy, has presented basically initially with a progressive weakness since the age of 3 years. Sorry, I lost my screen. I'll just try to go back to my screen. Since the age of 3 years, basically. And since that age, basically, he has been lost on the care system. So you can imagine it was almost like for more than 5 years until he was diagnosed and started on treatment on golodirsen therapy since March 2023. This is one of the exon skipping therapies that Dr. Tabaraki spoke about it. That is amenable for patients who have 45 to 52 exon deletion, as it is connecting to exon 53. Unfortunately, since he was a latecomer, he lost his ambulation since last summer, I mean a few months ago of 2025. Otherwise, he has good school performance. He is usually, as most of other children with Duchenne muscular dystrophy, as already shared with the case with Dr. Tabaraki, using steroids or prednisolone, weekends only protocol, as well as for bone health, including calcium and vitamin D. And that is something important that we usually look at it, because we need to make sure that the patient is receiving a standard of care. A treatment for bone health, steroids is gold standard for all patients with Duchenne muscular dystrophy, regardless whatever their genotype is, or even what's their ambulatory status is, since steroids actually is very useful even for those who are already wheelchair bound or even bed bound, given its positive effects on cardiac and respiratory function. His North Star, as you can see, it was 4 out of 34. Those are functional outcome measures that we are utilizing in monitoring our patients with Duchenne muscular dystrophy. His performance of the upper limb, it's relatively good, 38 out of 42. That's again as of a year ago on August 2024. His 6-minute walk test was not applicable since he's lost his ambulation last time. He has no other systemic complications, as already we alluded to multiple times during this talk, that those children usually they will have cardiac or respiratory involvement. However, thankfully this child, he didn't have any systemic involvement yet. So if I just give like a brief overview about the PMOs and exon skipping therapies. So exon skipping therapies, as chemically wise, it is what is called phosphorodimidate morpholino oligomers, which are synthetic molecules designed to modify gene expression by skipping a specific exons. And this kind of mechanism of action of medicine has been utilized actually in different diseases. As all we lumped it into what is called antisense oligonucleotide. So you have this kind of supplementary RNA, it works at the RNA, and as already mentioned by Dr. Tabaraki, trying to modify the phenotype of such patients from Duchenne patients into Becker patients. Hopefully, this kind of exon skipping therapies will produce partially functional dystrophin protein and helping those patients by prolonging their ambulation and slowing their progression of the disease. So that is in a nutshell, that's how they usually work. As already mentioned by Dr. Tabaraki, we have 4 different exon skipping therapies, which can address around 30% of DMD mutations, Duchenne muscular dystrophy mutations. We have different types of mutations on Duchenne muscular dystrophy. And that is one of the things nowadays that we have to look into the genotype of Duchenne muscular dystrophy, not just only to confirm the diagnosis, which is important, however, also to see if the patient is eligible for any of the newly approved therapies that the patient might benefit from. So if we are thinking about those kind of exon skipping therapies as a biological activity, as a proof of concept, they have a 16 to 29-fold increase in the dystrophin expression and by exon skipping. Dystrophin shown to restore actually dystrophin-associated protein complex. And how this is translated from basic science into a clinical benefit, that it should slow the decline in ambulation and pulmonary function compared to matched natural history controls. Safety profiles, relatively, they are fairly very well tolerable with no serious side effects that has been reported so far utilizing those exon skipping therapies. So if we talk about the golodirsen or the exon 53 skipping, which is utilized in this patient, it has been proven through different clinical studies. The main one was in phase 1/2 clinical study with open label extension up to 6 years, utilized in boys between 6 to 15 years with DMD, who are already on a backbone of steroids with ambulatory status when they started this study. So it was found that the loss of ambulation at 3 years was 16% in the active or in the treatment group for those who received golodirsen, compared to 22% basically. So there is 91% risk reduction in the active treatment group. And the time to loss of ambulation at 6 years, and that's when the study was concluded, median by 5.4 years with those who are treated with golodirsen, compared to 3 years with the external control, leaving us with around 2.4 years delay with a good 47% reduction. Not just only at the ambulation, because as we mentioned already, Duchenne is multisystemic involvement and respiratory is a major component that forced vital capacity. Annual decline was only 2.9% in the treatment group who are receiving golodirsen versus 6.7% in the external control. That means there is 3.8% less decline in the active treatment, which is meeting its statistical significance. Delay to nighttime ventilation was not observed in the active treatment. However, from the natural history study, if we just compare it to the natural history study, at least a good 7.5 years compared to the matched controls. So if I move on to the next case again, who is again another 11 years old boy, who unfortunately we lost 2 patients who lost their ambulation this summer by August 2025. His genotype was exon deletion at 42 to 52. He was on golodirsen bi-weekly, and I will speak about this issue actually, that we are facing some challenges with such patients, and hopefully seminars like this would address those kind of unmet needs or those kind of struggles that we as healthcare providers as well as families are facing in delivering the best care or treatment for such patients. He was receiving it on bi-weekly. Ideally, it should be once a week. He was already on prednisolone as well as on vitamin D and calcium. He was started again since August 2023, so almost 2 years ago. However, there was multiple delays due to different reasons, and he was living outside the city, so this was delaying actually his infusions. This led to interruptions on multiple times. So this affected actually his compliance and his benefit for those PMOs. And unfortunately, those kind of PMOs are short-term living. That means they should be infused at regular intervals. Once they pass their duration or their time, usually they will be they will lose their efficacy. We are hoping what's coming in the pipelines, the PPMOs or phosphorylated basically group from the same compounds will be last longer, and this will improve compliance with improved efficacy for such a group. This patient, his 6-minute walk test was 250 meters on December 2023 after starting his exon skipping therapy. As I said, he lost ambulation just on last summer. His North Star scale was 7 out of 34 in December 2023. And his performance of upper limb in this patient was not done, unfortunately. His cardiac examination was normal with good ejection fraction. And his respiratory, he didn't have any respiratory issues. However, pulmonary function test, which is basically, it needs some cooperation with the patient, was not that reliable. He has secondary osteoporosis. You will see that a lot of complications we are facing with our patients for multiple reasons, including the Duchenne itself actually affecting the bone health. Steroids that we are giving, again, affecting the bone health. They are those who lost their ambulation, of course, adding also another risk factor for affecting of the bone health, leading to osteoporosis, sometimes even pathological fractures. He started to develop some sort of early scoliosis, and he was referred for orthopedics for that reason. He have no developmental or cognitive issues for this patient. So my third patient, actually, who is 7 years old, who is in, he had exon 46 to 47 deletion. He started already with baseline daily fall, so he is a little bit earlier. He started to walk gait by the age of 4 years, similar to the case that was already presented by Dr. Tabaraki before he was started on his casimersen therapy. So that is basically 45 exon skipping therapy. He was started as of last year, or he is close to 2 years now. However, he started for 5 months. However, he had progressive weakness. After cessation, it was stopped, this medication. It was stopped by the family for almost close to 1 year before it was just resumed back actually on last summer. And we have noted that like there was a clear correlation about his rapid decline during the same time that he was not receiving his treatment. There has been no respiratory or palpar symptoms, and we are not expecting this at this point of time or this age basically for this patient. So there is decline in his functional performance with difficulty with the stairs. Relatively, he is considered early ambulatory. We try to subdivide the phases in patient with Duchenne into early ambulatory versus late ambulatory. However, he should be in early ambulatory, but he is acting as if he was late ambulatory, actually. His latest 6-minute walk test that was just done last summer was 261 meters. That dropped down actually from 320 that was performed just 2 months before. His latest North Star, again, it was 18 out of 34. Again, this is one of the functional measures that we are using that dropped down from 23. His performance of upper limb was 40, which reflect, again, a good preservation of his upper limb function. And sometimes, actually, that is something to highlight, because one thing that we always focus on as clinicians that we are, or as treating the neurologists, that we are focused on ambulation. However, actually, loss of ambulation was not something that was the major concern in a study that was performed in a lot of families who are taking care of boys with Duchenne muscular dystrophy. And they found that actually loss of the hand function was their major concern, and their bid rollover was also another concern. So it was not loss of ambulation. Although loss of ambulation as an objective marker is our goal, is or our milestone, major milestone, that's if it's lost, we usually tend to stop any kind of medications. So given this casimersen, so just to highlight this, this has been approved based on the Essence trial. That's a phase 3 double-blind placebo-controlled trial that was followed as most of the other trials by open label extension, that was utilized in or studied in boys between 7 to 20 years of age. Again, all of those medications has been studied on a backbone of good corticosteroids and other standard of care guidelines. So once again, as a proof of concept that the dystrophin expression showed significant increase in truncated dystrophin versus placebo after 48 weeks, so almost 1 year, that was quantified by Western blot and immunohistochemistry. Exon skipping increased in exon 45 was observed consistent with biological activities of a lot of those PMOs. And as a functional outcome, that's what we are interested in, that longer term functional endpoints, including 6-minute walk test and pulmonary measures, are being collected now in the open label extension. And there is an early trends generally aligned with expected stabilization pattern seen with other exon skipping therapies. And still the full results is under evaluation to see this open label extension. My fourth actually case again is an 11-year-old boy. He has exon 52 deletion, so he was started on eteplirsen, again on addition to the routine steroids that we usually utilize. He has borderline IQ of 79, as already mentioned by Dr. Tabaraki, that sometimes we find actually speech delay in addition to motor delay in younger boys. And older boys, sometimes they have this kind of learning difficulties, or sometimes even intellectual disability, because certain isomers of the dystrophin protein actually is expressed in the brain. And if that's affected, that indicates that it's important not just only for the muscles, different type of muscles, cardiac, respiratory, skeletal muscles, but also for the neuronal cells. This patient was started on eteplirsen weekly, then bi-weekly due to, again, transportation issue. He lost his ambulation, unfortunately, over the last few months. He started also to develop cardiac dysfunction with mild left ventricular dysfunction, with mild obstructive sleep apnea and scoliosis recently over the last few months, with some hepatic steatosis. Unfortunately, another issue that we are facing in those children, given that they are losing ambulation with steroids, so there is a weight gain, significant weight gain, that's affecting their metabolic metabolism, and with a lot of endocrinological issues that could lead to even insulin resistance. That will also add on to the other complications, including bone health, etc. This patient physiotherapy scale North Star declined actually to 0 out of 34 on last August. It was like 9 out of 34. That was just done a few months earlier, like almost 6 months before. His 6-minute walk test was only 105. That declined from a year before, actually from 174. He has ejection fraction around 45%, so it was kind of borderline. Again, it seems he is already on the severe end of the spectrum by showing restrictive pulmonary function test with OSA that improved after tonsillectomy and adenoidectomy that was performed for him. So again, just to share some data about eteplirsen or exon 51 skipping, the studies that has been used, there are multiple studies, 201, 202, ProMovie and Evolve, with follow-up for up to 6 years, and hundreds of patients were included. Boys with confirmed, again, DMD at this age were included between 7 and 16. And again, the endpoint was a proof of concept as dystrophin production measured by Western blot, again, using similar primary or functional measures, 6-minute walk test, forced vital capacity, and loss of ambulation and safety. And if you can see here that in the eteplirsen treated group, there is a decline in the 6-minute walk test by around 6 to 8 meters in the treatment group versus 133 meters in the matched control or natural history. That is statistically significant. Again, the median time to loss of ambulation in years was about 15 years. However, in the matched control was 13 years. So that means there is a 2-year delay in those who are treated with the eteplirsen compared to the matched control. For the annual rate of decline in the forced vital capacity was 3.5% almost in the eteplirsen treated group versus almost 6% in the natural history group, with a good 6 to 7 year delay in the treatment group. The hospitalization and ER reduction, because those kind of patients, they are need frequent admissions, ER visits, etc. It reduced those kind of hospitalizations and ER visits by a good 1/3 in the treatment group. So as you can see, actually from our cases, there is a common theme, there is a repetitive theme that we are talking about. To start with is the one that is highlighted already by Dr. Tabaraki in terms of the early diagnosis, early identification, because the common theme, except for one case from the cases that I presented, that actually all of them, they have started a little bit later already. They were already in the late ambulatory phase, which reflect maybe that they are not either a good candidate to start with, or actually they were already later downstream in their course of the disease, affecting their benefit from the treatment. So we need to improve the earlier diagnosis for better and earlier intervention. Another thing, those kind of medications actually are given through IV infusions, requiring either a good setup through home health care, or the patient or their family has to come to the hospital to receive their treatment. So we need to work through different patient support groups to improve the compliance for those medications. Once again, that is something that for all PMOs shared with, that they have to be infused on a weekly basis. And that's probably not something practical if we are talking about major cities like Riyadh, or even in small towns, to be honest. It's a huge burden for patients, for their families to come to the hospital every week to receive their IV infusion. And that is something that is affecting the benefit from those treatments and compliance as well. And as you can see from the shared cases that I presented earlier, that some of those cases are actually either there was an interruption due to social family issues, etc., or poor compliance. One more thing that we have to agree on, and that's regardless of whatever treatment they are receiving, regardless of anything else, all of those medicine has been shown to work only in one case, that is on a backbone, again, of a good standard of care that is received, meaning that the multidisciplinary team approach that Dr. Tabaraki already mentioned, good compliance to steroids, good compliance with physical therapy and rehabilitation team, regular follow-ups and visits with those basically different providers or multidisciplinary clinics. So this is very, very important. Actually, that has to be addressed before even talking about different treatments that should be received. So standard of cares must be actually, it should be actually the gold standard as a first line for all of those patients. Last but not least, exon skipping therapies are effective for Duchenne patients with robust evidence of delay progression in muscle and pulmonary function with prolonged ambulation. And on the long term, actually, there will be reduced healthcare utilization. So if they are compliant, that means they will be not losing their ambulation as early as expected in the natural history study. That means we will be reducing hospitalizations, we will be reducing ER visits, we will be reducing their chest infections, etc., and their different visits to different healthcare providers, hoping this indirectly will reduce the burden on the healthcare system. So I think that is all that I want to share from my cases that I have here so far. I will stop share my screen so that I can go with the questions that we have it here before introducing my next colleague. Okay, so I think there is a question: what is the lowest CK you have seen in toddlers, young kids with DMD? I don't have actually a number for that, but I have to say that we have seen cases that usually we are talking about 1,000 or in the range of thousands, usually in children with dystrophinopathies in general, and that's the range that we are usually talking about it for children with Duchenne muscular dystrophy. There is another question is, what do you think about efficacy and safety about gene therapy or Elevidys? I think this is beyond the scope of this talk, but I am more than happy to address this question later on. there is a question is, when do you recommend initiating disease-modifying treatment in DMD? And at what point should cardioprotective agents like ACE inhibitors or beta blockers be started in relation to this? So, so usually those kind of disease-modifying therapies, as already mentioned by Dr. Tabaraki, that some of them, they has been even used at the age of few months old. Usually, typically by the label, we started them. I mean, even in reality, in real life or clinical practice, by 6 years of age or above 4 years of age. That's when we usually start them. For the ACE inhibitors, typically, we started by the age of 10 years, regardless of their symptomatology, of course. If they become more symptomatic through our cardiology colleagues, before that time, they should be started earlier than this. Another question is, who wouldn't be a suitable candidate for disease-modifying therapy in DMD? So for disease-modifying therapies, we are talking about specific or genotype-specific medications. As you can see, if we are talking about exon-skipping therapies, so exon-skipping therapies is only for certain deletions that is already shared by Dr. Tabaraki, 45, 51, 53. Those are the only one that is available. We have also read through like atalorin, and we have the gene therapy. Recently, we have also givinostat, which is the first one that is not genotype specific. Regardless, it's for all DMD patients with no exclusion. What is the life expectancy for an individual with DMD? So probably I mentioned that briefly on my talk, and usually it's different between patient to patient. However, we are usually speaking about in the late 20s. It depends again from patient to patient, but that's usually in the range of late 20s or early 30s as most. Okay, so I think that those are all the questions that I received here in the Q&A box. So if there is no more questions, so I will go to introduce our next speaker, who is Dr. Majid Aziz. Dr. Majid, he is a friend of mine. He is a senior pediatric neurologist working in the Department of Pediatric Neurology at Sheikh Khalifa Medical City in Abu Dhabi. Dr. Majid Aziz, he is a senior pediatric neurologist here in the GCC country with a huge, actually, professional background, starting from Australia through UK. Dr. Majid Aziz has a huge experience in treating patient or treating different patients with neuromuscular diseases, specifically for Duchenne muscular dystrophy. Without any further ado, Dr. Aziz, the floor is yours.
Bismillahirrahmanirrahim. Thank you very much, Dr. Mohammed and Dr. Maya and the team for this kind invitation and to share some of the real world data and real world experience. And I'm grateful to Dr. Ibrahim and Dr. Mohammed for setting the stage. As we said, there may be subtle overlap, but I'll try and keep it simple because I know our audience comes from different backgrounds. So as with my rest of the colleagues, the talk is sponsored by Gen Pharm. And I'm going to introduce to you two cases that I have been following up and have been involved in the care. Actually, the second case is of two siblings. And as my other colleagues, two speakers have highlighted, the importance of the disease-modifying agent and how this has kind of evolved the natural history of Duchenne muscular dystrophy in the last 5 years. So if I go through the basics, I mean, Dr. Ibrahim and Dr. Mohammed have gone through these details, but to simplify, because I think if we have a basic concept of understanding what the condition is, and some of the colleagues, attendees were earlier asking about, what does DMD involve? So basically, dystrophin is one of the sarcolemma muscle wall protein that anchors the muscle wall to the actin cytoskeleton, which is the contractile protein of your muscle. And when you lose this anchorage of the dystrophin, your muscle wall or the muscle becomes quite unstable. So with activity, with movements, what actually happens is that you break down the muscle, you set up a cascade of inflammation and fibrosis, and you have the associated symptomatology of the muscles with weakness, calf hypertrophy, and involvement of the other muscles. Now, the dystrophin gene is one of the largest genes in the body, in the human genome, with about 79 exons. And you've seen this picture before, and that it gets translated into a protein, dystrophin protein. Now, when we were training earlier in the 2000s, and genetic testing was becoming available, at that time we didn't have the facility of studying the genome or the whole dystrophin gene, and we used to rely a lot on muscle biopsy. So any child you would suspect of having a muscular dystrophy or a DMD phenotype, and with a high CK, majority of these children would undergo muscle biopsy with immunohistostaining, and they will show you this kind of dystrophin protein staining. If it had patchy staining, we would label it as Becker's muscular dystrophy, and if there was lack of the dystrophin staining in the muscle wall, then this was a classical Duchenne muscular dystrophy. But over the course of time period, as our advent of genetic testing became more and more sophisticated, we were able to understand this condition better, identify the different types and variation within the genetics of Duchenne muscular dystrophy. And as you have heard my colleagues, that now treatment is being targeted with a precise mechanism to change the course of Duchenne muscular dystrophy. So this is kind of a general brief overview, basic overview, just to keep in mind and how this has evolved in terms of the new treatments that are coming in the pipeline. So colleagues have asked, attendees have asked, what is the natural history? Dr. Ibrahim already touched on this, but this was kind of a natural history that we used to see with our Duchenne muscular dystrophy patients, provided they were getting standard of care. And as Dr. Mohammed highlighted, the most important and the key aspect is the standard of care in terms of physical therapy, rehabilitation, bone health, cardiovascular health, the respiratory care, and keeping their health at optimum, because this is ultimately that would determine their course of life and the quality of life. And depending on which part of the world you are, how much access to healthcare facilities you have. I, being trained, in the Western world, in the UK, Australia, and spending some time in the US, have seen a lot of variability. And then now working in the GCC, again, being quite privileged within the UAE with the access of, healthcare facility and access to a lot of resources, ultimately determines the outcome of these children. And as it was highlighted, that majority of the children, what we aim for and the experience in the modern world is to have a diagnosis between 4 and 5 years of age. That's mostly where we would diagnose our patients. But you will see, we've seen some cases from Dr. Mohammed, and I'll highlight a couple of cases as well, where there has been a delay because of their clinical presentation or lack of, identification of signs in these children. And as Dr. Mohammed highlighted, that usually with our previous standard of care, with our previous standard of treatment with steroids, use of ACE inhibitors, cardioprotective treatment, most of these kids would lose their ambulation by about mid-teenage and pass away in their late 20s and 30s. But now with the advent of therapies, what we are going to do is we are shifting this natural history of DMD. So the first case I'm going to present is a 7-year-old boy, Zayed, and this is a very interesting case. He was born after IVF pregnancy. He was noted to have motor delay and difficulty with climbing stairs. And luckily, one of the pediatrician who he went to see was aware and did his typical blood test and identified that the CK was over 21,000. So he was diagnosed at a very young age of about 2.5 years of age. He has a deletion between exon 46 to 51 in the dystrophin gene. And as you would know, just to catch up here, so you can see between exon 46 to 51, there was deletion. And I always say that this is like a puzzle. You can see that there are different shapes. And the exon therapy, skipping therapy, as highlighted, is like a knockout therapy that you kind of a knockout and try to put the puzzle back together and to make it into a functional protein. And now, kudos to this family, as Dr. Mohammed pointed out, that a lot of these exon skipping therapies are intravenously administered on a weekly basis. And this child lives quite far away from Abu Dhabi. And, kudos to their family with the dedication of bringing this child every week to Abu Dhabi for having weekly infusions. And he was started on prednisolone early with vitamin D and provided with the standard of care. And as you can highlight and see that his one of the parameters, the 6-minute walk test, were always more than 60 meters, and his power remained quite, MRC power grading was 4 plus. As the gene therapy started to evolve, and we had access to this in the United Arab Emirates, he received it was in November 24, not November 2025, so almost a year ago. So he was on the exon skipping therapy for nearly 3 years before he received the gene therapy. So this exon skipping therapy provided us with a very good bridging gap by maintaining his motor function, maintaining the stability of his muscles, with the opportunity that when the gene therapy became available, he received that in November of last year. And initially, we do see this phenomena that your CK levels do go up. His baseline was 12,000, they almost double. But within a span of 6 months, the CK levels have dropped down to 7,000. And the other thing to highlight is that within 3 to 6 months, you can see that his North Star ambulatory scores started to improve. His time to climb stairs and time to rise started to improve as well. And almost within 8 months, you can see that there is a significant improvement in terms of his motor abilities. Now, just to highlight, Dr. Mohammed has already touched this on briefly, what the exon skipping therapy means. And at the moment, we only have it for knockout for 3 exons, which is number 45, 51, and 53. And basically, the whole concept is to join the chain together. So this is kind of an example that I was mentioning to you, that you have these kind of a puzzle, a jigsaw that is connected to with one another. When you have a deletion of a set of exons, and by just knocking out that exon, we can reconnect those exons to make it into a functional dystrophin protein, though it would be a shorter chain, but would still be functional and would prevent the child having from a severe disease to a mild to moderate disease. So one of the downside of this is that you need to have IV access. It involves weekly infusion, so it requires a lot of commitment from the family to bring the child regularly to the hospital, provided that if you don't have, home care facilities available where they can have home infusions. But because in our Middle East, the families are quite widespread, and access to tertiary facilities and access to these very specialized treatment is only sort of available in one of the major cities. So that would involve a lot of commitment from the families to travel. And a lot of these functional tests that have been highlighted, my colleagues have shown quite significant improvement. And usually the exon skipping entails for about 13 to 15% cases of the DMD, depending on the type of mutation and the deletion that involves. And research studies, as Dr. Mohammed highlighted, that the biopsies have shown that there is low level of dystrophin produced with these exon skipping, and it slows down the rate of decline in ambulation and in the natural history projection of these children. Now, in terms of the microdystrophin gene therapy, I think one of the attendees asked earlier. So this is based on the concept that they've identified that one of the patients had a milder form of Duchenne muscular dystrophy, and based on his availability of genetic makeup, it was decided that because of the big size of the dystrophin, can we chop it down into a mini dystrophin gene, use the exons that would translate into a more effective, or at least a functional dystrophin protein. This concept was based previously, on a lot of other gene therapies like SMA, MLD, a lot of other neurogenetic conditions where AAV vector virus has been used, where the microdystrophin was sort of packaged and it's delivered as a one-off single infusion to deliver trillions of these virus vectors, with the idea that the delivered DNA translates into the effective protein. And this is kind of the animation to show you how it gets translated into the nuclear. It still remains episomal and gets translated through the ribosomes to develop the dystrophin protein. And Dr. Mohammed already highlighted, how things have evolved over the course of time with these cases. So one of the major side effects that we see is the post-infusion immune reaction, particularly transaminitis, and all these children with like SMA and DMD require a short course of steroids. The studies have shown that from the biomarkers that the CK levels reduce over a course of time, and the muscle biopsies show a lot of dystrophin expression. And it has also shown from the functional aspect the stabilization and improvement in the North Star Ambulatory Score, which we've highlighted. It's a set of 17 aspects. The maximum score is 34 if they achieve. And we see that there is an improvement and plus a slowing in the decline of the other functional tests. There have been reports of, mortality, for which reason the trials in muscular dystrophy and the Elevidys was put on hold for a period of time late last year, but then following new recommendations, when they expanded the use to non-ambulant patient, I think the latest recommendation is to be used between the ages of 4+, but in ambulant patients. So there is currently a limitation for use on the non-ambulant patients. So my second case is our two brothers. They are currently aged 12 and 13. And this is going to shift to a different aspect of disease-modifying therapies. Now, as you can see, that these two brothers were diagnosed quite late in their first decade of life. And they had long-term motor difficulties, they had speech delay, they had learning difficulties and features of hyperactivity, which my other colleagues have highlighted. One of the key aspects could be learning and speech delay with tiptoe walking. So always in a boy, think of DMD or muscular dystrophy. And when interestingly, there was a family member who passed away in his early 30s, were reported to have similar features. But as you can see, there's a lot of social stigma in our society, and information doesn't get shared when families come to you in clinic. But later on, we found out that the uncle had Duchenne muscular dystrophy. Their initial presentation CK was over 6,000, and the genetic testing confirmed that they had a nonsense mutation in the DMD gene. So as Dr. Mohammed Ali pointed out, that there are different types of genetic mutation. There can be deletion, duplication, or point mutation, or causing this nonsense mutation. And one of the therapies that has been available over the course of time was ateliurium, which is the read-through therapy. These two siblings were started on that based on this particular mutation, where it's only effective or used in this type of nonsense mutation. They were also getting started with the standard of care with steroids. And currently we are awaiting the approval for the gene therapy. And to highlight that, though their diagnosis was late, they had motor difficulties. Now, being in the early teenage, and this is what I'm trying to highlight, is that this is the age where we would expect them to have difficulty with stairs, And I mean, they lose their ability to climb stairs and start to become non-ambulant. And you can see that though they have difficulties, they are still able to climb the stairs. They're able to rise from the floor with minimal help, and they're still ambulant. There's no respiratory problems, but the older teenager has developed mild to moderate ventricular dysfunction, for which he's on the ACE inhibitors and diuretics. So coming to the ateluren, which is the stop codon read-through treatment, it's one advantage is it's an oral medication, and basically the concept is that your normal protein, when the ribosomes is reading through your messenger RNA, is developing your truncated protein, and you develop a functional protein. But what happens is that when you have a nonsense mutation, it creates an early stop. So basically, the protein that you're developing is not fully functional. It's a truncated dystrophin, and they may have, slightly better than the ones with the deletion, but again, would be severely affected. But what the ateluren does is kind of a reads through and facilitates the reading by adding that missing amino acid, so that your ribosome is reading through that messenger RNA and kind of develops a functional truncated dystrophin protein. So I hope that sort of helps them understand. Now, over the course of time, there have been mixed studies. The FDA did not approve this treatment in the US, but the European Medicine Agency had approved it with certain restrictions. And there have been mixed outcomes of the trials, but in terms of the real world data, it showed that children who were receiving it continued to be ambulant, and it did help in reducing their decline in motor functions. So just kind of comparing the two major therapies, disease-modifying therapies that we have, the exon skipping and gene therapy, already highlighted by my colleagues. One of the aspects of exon skipping therapy is that it's lifelong, it's weekly infusion. It does help to increase the dystrophin by moderate amounts. It does help to reduce the decline and maintain some function, but obviously they will pass by with the course of time. And it's at the moment, we only have it for specific type of deletions, not for every type of mutation with the dystrophin gene. On the other hand, the gene therapy, apart from, again, approved for how I'd say it is contraindicated in certain type of mutations, like if they have a deletion in the exon 8 and 9, and then we do not use the gene therapy in those children. We also know that in certain types of mutations, for example, if it's in the 1 to 17 or 49 to 70, then those children have severe form, plus the risk of immune response is much higher with the gene therapy. Again, the question here is that we've been using it, real world data, long-term data is still awaited. And the question remains that this single gene therapy, will it last, and will it keep on expressing enough dystrophin for lifelong? But obviously one of the hindrance is the high cost and the complexity and availability. So what's in the pipeline, as Dr. Mohammed highlighted, that new anti-sense oligonucleotide exon skipping therapies are coming in. There are a few in pipeline. The gene therapy modification with especially safer caspids to reduce the immunoresponse and reducing the payload of the amount of virus that may be required would help in terms of the immune response. And obviously, there is still preclinical trials of using gene editing is still being undertaken, but it's kind of a long way ahead at the moment. There are big issues. Obviously, every meeting, a neurology meeting, neuromuscular meeting, we meet, and there are talks of, for example, newborn screening, early detection of some of these devastating conditions like DMD or SMA. And I know in this part of the world, we are starting to implement pilot studies of newborn screening for early identification of these children to be able to provide this intervention early on to improve their quality of life and prevent from a decline and a devastating condition. But again, these treatments are extremely expensive. the question again remains that do we offer it to all children, insurance coverage, financial support, age restrictions, like with the DMD outcomes, we saw that when we opened up the gates for non-ambulant children, these were big kids, they were getting a larger, bigger volume of infusion and the virus load. We started to see sort of serious complications with that, and mutation eligibility, whether we can expand to other mutations where we know there may be slightly high risk of things. And again, how do we get these treatment funded? The second most important thing is that families feel that with gene therapies, these are curative, and once they receive it, it may reverse their condition, which is not the case in most of the gene therapies we have for other conditions as well. So it may stabilize the condition at which they are and kind of prevent their serious decline. And again, managing the expectations of these families with the hope, it becomes a big challenge for us as clinicians. So just to conclude in the end, I've sort of brought in two cases where one of them had a very early diagnosis, started on disease-modifying treatment with exon skipping for 3 years. And then when gene therapy became available, the child was taken to the service. And you can see that the quality of life, the functional ability of this child has sort of almost slowed down the natural history, the natural process of the condition. And this child is performing very well compared to children who, if were just receiving only standard of care. And this shows how the paradigm shift has happened. On the other hand, a delayed diagnosis with a slightly different mutation and a molecule that can help to develop sort of functional truncated protein with the use of atellurine, though the trials have had mixed results, but natural history, the natural world data showing some benefit of that. So I think there's still a long way ahead. There are challenges for us as clinicians. It is going to bring up a lot more burden on the healthcare services, these children, despite, with all these treatment. And again, I second Dr. Mohammed's notion that despite these treatment, they still require the standard of care, which all children need. And I think that is what, even if they get these therapies, they still require ongoing care to maintain that quality of life. So with that, I will come to closure and I'm open for questions.
Thank you very much, Dr. Aziz, for this astonishing presentation. So looking at the Q&A box, I think we have a couple of questions for you, Dr. Aziz.
Please.
So there is a question. Basically, I am a cardiologist and I have seen a few cases of DMD with cardiomyopathy. How much percentile of DMD with DC, I think, saying with dilated cardiomyopathy? And is there a new remedy to treat and increase the span of life?
I mean, as you highlighted early, that these children in the first decade of life with the standard of care would need at least annual basis of their cardiac assessment. But after the first decade, at least, 6 monthly, provided how their cardiac functions are and based on the ejection fraction. And the recommendation is to start on ACE inhibitors early on before we start to see any features of the dilated cardiomyopathy to prevent things. So the steroids had a role in sort of preventing that. The big question is, with the exon skipping and particularly the gene therapy, whether this will have a cardioprotective role. We are seeing some data on that, but I think it's still more information is awaited to see, like 10 years down the line, when these children who had received the therapy in early stages or in late stages, how their cardiac outcome has evolved. Some of the data or published data in case series suggest that there is stability, but yet we are still waiting for the trial data to come out for long term.
Perfect. The second question is saying, could you clarify why exon skipping therapy can only target specific exons? What prevents us from applying the same concept across all DMD mutations?
So I think it's based on the commonest mutations and the deletions that we have seen. And because most of these have been developed in, the Northern America and Europe, and their population has a very specific type of deletion in these regions. So I think the interest has come in terms of development in those particular exon skipping. Obviously, our population has also the commonest in those regions, but can be quite variable. There are few exon skipping in the pipeline being developed, but at the moment, the commercially approved available is only on 3 exon skipping. And there's a very good website called Dove, and you can actually, it's like a tool that Khaled from GenFarm shared with me, and always very helpful. So what you can do is you can put in the type of deletion in this tool, and it will highlight what would be the most appropriate exon skipping or therapy available for children with DMD.
Perfect, Dr. Aziz. I don't see any other questions here in the Q&A box. So I think if there is no other questions here, I would like to thank all my colleagues, Dr. Tabaraki, Dr. Aziz, for their nice cases and difficult cases that we are facing actually in our daily practice. I think with this concludes our session. I just want to remind you again, please, is to fill the survey, the post survey, to claim your CME hours. Let me know, Dr. Hussam, if there is any other things, or I think with that we can conclude our session.
Thank you so much, Dr. Muhammad, for the great moderation and speech, and thank you, Dr. Majid, for the great presentation. I just want to remind everyone that we will be sending certificates of attendance within 1 week of today by email, and we will be glad to. You can always review the recording of the webinar at the IVPN library, which is available at the website on the screen, ivpnnetwork.com. And we would love to have you always on social media to stay informed of our future activities, and follow our IVPN NeuroPsychiatry LinkedIn page. And until we meet you again, thank you so much.
Thank you very much, all. Thank you, Dr. Mohammed. Thank you, Dr. Hassan and Dr. Maya. A very good evening to everyone.